I'm just going to give a couple of minutes for everyone to join. Hi everyone, my name is Oishi. I'm currently in third year, and today we're going to talk about reproduction, which is one of my favorite topics, and I'm really excited to teach this today. So just before we start, if anyone has any questions, please do unmute and ask. Um, Other than that, I hope everything's okay. Can everyone hear me all right? And if there's any issues with the pace, just let me know and I'll slow down or speed up if necessary. There is quite a lot of content to cover today. But yeah. Is my mic working all right? Can everyone hear me? Okay, let's get started. So we're going to go through the syllabus. And as you can see, there is quite a lot, but I've broken it down into four main sections, um, which is like lines up quite neatly with the timeline of everything. And I have included a lot of diagrams because I find it quite useful myself to learn from diagrams. And I think if you do choose to write essays on this, it would be a good idea to add in as many diagrams as possible to save on like typing and words and things. And then you can refer to them in the essays. So it's really good. Um, Again, any questions, just unmute and ask. Let me see if I can open up the chat at the same time. Um, yeah, okay, I think it should be fine. Okay, I can see the chat at the same time. So if anyone has any questions, do feel free to type them in. And other than that, let's get started. So let's start with fertilization and implantation. Ooh. Again, I have included a lot of diagrams. So hopefully you can either screenshot it or later when they send around the slides, you can just take them. And it's useful for revision as well and really useful for part A's as well. But other than that, so the first step is ovulation. And this happens on day 14 of the female menstrual cycle, which is typically 28 days, but it can vary between women. And it is important that you match, like when we talk about ovulation, there's folliculogenesis and oogenesis, which again, I have another diagram that will come on to. But ovulation happens on day 14 and it causes the release of an oocyte into the peritoneal cavity. And as you can see, it goes from the fimbriae, which is like finger-like projections, through the infundibulum, which means funnel, ampulla, isthmus, and then eventually into the uterus, where it can implant and hopefully manage to survive, which will lead to a successful pregnancy. So of course, ovulation has to match up with sexual intercourse in order for there to be a successful pregnancy. What I mentioned earlier, oogenesis, folliculogenesis, and I've got this diagram as well. And then you can see the release of the polar bodies in this diagram. So as I was saying, ovulation has to match up with sexual intercourse. So I don't know about you guys, but I was taught with point, squirt, shoot, which outlines the different stages. So first you have so erection is parasympathetic, vasodilation, PNS. Then emission is sympathetic, and then ejaculation is somatic. Ooh. Okay, so there are about 100 million sperm which are released into the female reproductive tract, but only 1% manage to get to the ampulla of the fallopian tubes. And again, this is another diagram which will be useful later on, maybe. I've just included it. But this is the order of everything that happens leading up to fertilization. Hopefully you can see my mouse, but first we have sperm transport, then capacitation, hyperactivation, acrosome reaction, zona pellucida penetration, and then finally oocyte activation and cortical reactions. I have briefly summarized each of the stages, but basically this is all the steps that lead up to fertilization. So although sperm can survive up to 5 days, the ovum only survives 24 hours, and that's why timing is critical. Um, so capacitation is the reaction where the sperm become the sperm plasma membrane progressively destabilize so that they can actually go and fertilize the egg because of the compromised membranes. And hyperactivation is when there is a calcium influx, which causes the sperm flagella to whip like crazy and swim really fast. So the acrosome reaction is when the sperm releases the acrosome. So this is the acrosome. And this happens when it binds to the ZP3 protein on the zona pellucida of the oocyte. And this allows the sperm to actually penetrate the oocyte, and upon penetration, this activates the egg, and various reactions happen, which make the oocyte membrane impermeable to prevent polyspermy and any issues with like chromosome numbers that could happen as a consequence. So if you do the reproduction module next year, you'll hear all about PLC zeta. But yeah. Oh yeah. So then the two haploid pronuclei fuse, and this causes a diploid zygote. I've added some questions, and I think that just because of part A's being multiple choice questions, some questions would be really useful to test and make sure, like, to consolidate things. It's just on the PowerPoint, so I'll give like 5 minutes, so you can all have a chance to answer it. It's not multiple choice questions. I've just written the answers. But meanwhile, if anyone has any questions, I'm more than happy to answer them. I did say 5 minutes, but I'm just thinking how much we have to go through. So let's just answer the questions now. We can go through them one by one. So oocyte receptor activating acrosome reaction. Oh, it's the ZP3. What does the acrosome do? It releases lytic enzymes to degrade the zona pellucida to allow for sperm penetration. What is the role of the cortical reaction? Ensures a diploid zygote is formed. What is the role of the zona pellucida? Plenty of roles. Acrosome glycosylation, 8 days. And we will come on to a little bit more about this. So let's talk a little bit about implantation. So as you can see, as I was saying, the oocyte travels, and hopefully it gets fertilized here. Then as it's dividing rapidly, it goes and attaches to the fundus, which is the top, or the like top 1/3 of the uterus. So On day zero, if we count day zero as fertilization, by day 5, the zygote reaches uterine cavity. Um, Here's another diagram, splitting it by the days. And then on day 6, apposition begins. So this is when the blastocyst hatches, and I do think it's quite funny. It's like well, it is an egg, but I just think it's funny saying it that it's hatched. And this is because the zona pellucida has completely degraded, and once it's hatched, it's sticky and it can actually invade the endometrium. So once it's hatched, it's ready to implant. Um, and then on day 7 is when we say that the actual attachment happens. So it's receptor mediated. And on day 8 and 9, there's like progressive invasion to ensure that the blastocyst is firmly attached. So the trophoblast cells proliferate and penetrate into the endometrium. And we'll talk a little bit more about this when we talk about the placenta. But basically, the trophoblast layer proliferates and differentiates into the cytotrophoblast and the syncytiotrophoblast. So the cytotrophoblast, um, so actually my extended essays on this. So you can have the invasive extravillous trophoblasts, which actually go and invade everything. And this is really important to ensure that there is sufficient like nutrient exchange and things like that. And also another interesting thing is that the trophoblast cells do secrete HCG, and this is important to maintain the corpus luteum to like keep going with progesterone secretion, production until the placenta can produce it by itself. So as I was saying, implantation occurs mainly on the upper posterior part of the uterus, and you can have an ectopic pregnancy when the blastocyst actually attaches outside of the uterus, typically in the fallopian tubes. And this is very, very dangerous and a medical emergency because the fallopian tubes can rupture and it causes internal bleeding, very dangerous for the mother. Okay, so now we'll talk a little bit about the placenta. So the placenta is a temporary organ that develops alongside the fetus, and it can actually affect fetal development. So there are many roles of the placenta, such as ensuring physical attachment of the conceptus to the uterus, allows for invasion of the endometrial tissue, transfers respiratory gases, nutrients, waste. The placenta is also involved in hormone synthesis via the maternal fetal placental unit. And it also acts as an immunological barrier. So the placenta fully takes over nutrition and all these things from 12 weeks and is matured by 34 weeks. So let's quickly talk about the development of the placenta. This can be quite confusing. So I've added Clive's diagram and broken it down by the primary villi, secondary, and tertiary villi. So why do we need the placenta altogether to like adequate development of the placenta? And this is because simple diffusion is not enough for the conceptus's metabolic demands. And so the placental development starts as early as 8 days with the trophoblast cells, and it forms a different villi. So let's go through the different villi. Oh, just before invasion, you also have the decidual reaction, which is when the endometrium has spiral arteries and it provides like blood and a lot of edematous fluid to promote secretion and develop the fetus. Okay, so primary villi. So this is usually on day 13, and the cytotrophoblasts invade the lacuna. Secondary villi, roughly 2.5 weeks. And you can see here is the mesenchymal core. And what separates that and the tertiary villi is that the tertiary villi actually has capillaries, connective tissue, and allows like blood to form, like blood to pass through. And this eventually, all these tiny capillaries become mature villi, and the mature villi are highly branched, and it's not like tiny capillaries, it's just blood can properly pass through and flow through. So usually the placenta only attaches like 1/3 into the deep into the endometrium. And if it's too deep, you can have pathologies like the abnormally invasive placenta spectrum, such as placenta icreata, or in extreme conditions, placenta pacrata. And is very dangerous because it can cause postpartum hemorrhage and maternal mortality. So here's a little bit more about the placenta structure and function. It might be a good idea to learn this diagram just in case it comes up in part A's. Um, but yeah, as you can see, there are different modes of transport for transporting gases or glucose. Um, Again, I've included a variety of diagrams in case anyone does want to write essays on this in part B, and then you can just learn the diagrams and then draw it out. And it is important to note umbilical vein, it goes into the baby, and then umbilical arteries, and this contributes to the fetal circulation. So this is carrying all the nutrients, umbilical arteries are taking away waste. So let's talk a little bit about pregnancy. Oh. So let's talk a bit about the maternal fetal placental unit. And this is because the placenta actually has an endocrine role. So the maternal fetal placental unit is responsible for synthesizing the hormones. So as you can see, I think this is a really good diagram in terms of understanding it. I don't know if it's realistic for actually doing it on an exam. But this is why HCG is important, because the corpus luteum initially, I think this diagram is better for it. So the corpus luteum helps maintain the um, estrogen, progesterone, maybe it's just progesterone secretion, until the placenta is fully developed enough to do it independently of the corpus luteum. Again, we'll talk a little bit more about the roles of estrogen and progesterone in terms of lactation when we move on to lactation. But I think that all the hormones are really important for maintaining a pregnancy, initiating parturition, all these things. So it might be a good idea to list out all the hormones that are involved in this module and the different roles and the functions of those hormones, and just memorize them for part A's. But basically, these are the 6 key hormones, and you can see each of the hormones' roles. So if you don't want to list it out, just copy this diagram or just read it like I did. And then you can see how the concentrations vary as gestation progresses. And I think this is a really good diagram because it says where it's produced from. Yeah. If anyone has any questions, feel free to ask them. But more or less, that's really what is the role of the maternal fetal placental unit. And now we're going to talk a little bit about prenatal genetic testing, or prenatal testing, really. So this is for allowing detection of any abnormalities of the fetus, which can occur in like 2 or 3% of all pregnancies in the UK. So this prenatal testing can be used for making diagnostic assessments later on. So really there are 2 invasive types that are really mentioned in the syllabus, and that's chorionic villus sampling, which actually samples the trophoblast cells. And then you have the amniocentesis, which goes in and takes a little bit of the amniotic fluid and then tests that for any genetic abnormalities. And because these are invasive, there is a risk of miscarriage associated with them. And it is limited to really genetic testing for trisomies like Down syndrome, Edward syndrome, Patau syndrome. Um, so ultrasounds, so again, you have non-invasive testing, and this really, in the case of ultrasounds at least, tests for structural anomalies like cleft palate, things like that. And you also do have cell-free DNA testing, and this is when small fragments of the fetal DNA could be taken from blood tests. But of course, with all this prenatal testing, it does um, raise questions about medical ethics and ethical questions about screening for non-life-threatening conditions. Um, yeah, very interesting. Um, so here's a little bit more about the invasive testing. And you can see like where each of the samples are taken from. And hopefully this helps us understand why there is an associated 1 to 2% risk of miscarriage. Okay, so this I understand I'm going really fast, but hopefully it's just a whistle-stop tour and you can click through the slides later. But now we're going to talk a little bit about birth or parturition. I don't know why they keep calling it parturition in the exams, and lactation. So childbirth happens at the end of pregnancy, and it's after 40 weeks, or at least we say 40 weeks is to term. And there's like labor involved, hormones, and depending on like medication, you can alter these hormones and induce labor earlier or help develop the fetus so that you can deal with, say, preterm labor, things like that. So before we can even start talking about birth, let's talk about what are the requirements for parturition. So first, you need to ensure that the fetus is mature enough and organs like lung, guts, liver, they need to be fully developed. And these are typically organs that form towards the end. And like clinically, you can see it in premature babies where they may have underdeveloped lungs and things. Or if you are having like preterm labor, then mothers can be given cortisol, and this hopefully helps mature the lungs. Yeah. So another thing that's necessary for parturition is that the uterus has to switch from a relaxed state to forceful contractions for delivery. And this is mediated by intracellular calcium and prostaglandins E, F, which we'll go on to. And this increases the number of gap junctions. And this is all like regulated by oxytocin, prostaglandins E and F, and you need to make sure that the uterus does have the appropriate receptors, so oxytocin receptors or those prostaglandin receptors. And clinically, you can give medication like misoprostol, which can cause these contractions. So this can be used for a medical termination of pregnancy or help with like postpartum hemorrhage to cause the uterus to contract and hopefully reduce the hemorrhaging. So you also need to prevent the relaxant effect of progesterone, and this is mediated by an overall change of from progesterone B to the more forceful progesterone A receptors. Um, so this is also controlled by cortisol, which also causes estrogen synthesis in the last few days. And finally, cervical changes. So you need the cervix has to become very loose and able to push out a whole baby, and this is mediated by prostaglandins again. So let's talk about the hormones in turn. I've included this diagram here to talk a bit about the cortisol reaction, like the role of cortisol in parturition. So as the fetus grows, the placenta and the fetal adrenal glands grow, and this increases cortisol secretion. And again, I do think this is a good diagram for understanding how it all works and how cortisol can cause, like how cortisol levels increase towards the end of pregnancy, causing all these changes and eventually birth. Um, so you can see the role of placental cortisol. So maternal cortisol increases, placental CRH increases, and this can be seen as CRH concentration is higher in women who deliver early and lower in women who deliver later. Um, and this was also shown in sheep cortisol. So now moving on to progesterone. So progesterone actually needs to decrease for birth, and you can see the effects of progesterone when you think about women in their third trimester and some of the symptoms they have, such as constipation, and this shows the relaxant effect of cortisol on the muscles, heartburn, so it's a more relaxed cardiac sphincter, reduced bladder and ureter tone, so increased micro nutrition because of the again the relaxant effect of progesterones, um, and the it's also involved in vasodilation and reducing diastolic pressure. Um, yeah, so these are all the relaxing effects of progesterone, but it's very hard to suddenly like take away all the progesterone. So instead, what the body does is that usually for most of the pregnancy, progesterone acts on progesterone B receptors, and then pro-labor signals cause the shift from progesterone B to progesterone A in late pregnancy. And these pro-labor signals may be like inflammatory signals caused by prostaglandin. So now let's talk about estrogen. So estrogen also stimulates changes such as developing more oxytocin receptors. The more oxytocin receptors are synthesized, it stimulates the formation of gap junctions between the myometrial cells, which allows for contraction to happen in synchrony. Prostaglandin secretion, uterine growth, and also supports the mammary gland duct system to prepare for lactation. Oxytocin, peptide hormone, stimulates uterine contractions for labor. So as progesterone decreases, estrogen increases, so there are more oxytocin receptors, and oxytocin drives prostaglandin synthesis. So prostaglandins E and F are mainly involved in this. And so if there are women who are struggling with labor, clinically, you can give them vaginal pessaries with prostaglandin F to help things move along. And let's quickly talk about the mechanism of parturition. So this is a positive feedback loop. And yeah, so stretch of the cervix causes hypothalamic oxytocin neurons to secrete oxytocin from the posterior pituitary, uterine contraction. The fetus moves further down into the cervix. So again, the uterus is stretched and it's all a positive feedback loop. And this is called the Ferguson reflex. So this all continues until the placenta is also expelled. So lactation. This is very short because, again, I'm only going to cover the high yield topics for the sake of time. And really, in part A's, it talks about what's the role of estrogen, progesterone in lactation. And estrogen is involved in growth of the breast tissue and progesterone for the alveoli. Um, and then oxytocin is also involved in lactation. So, so also, so prolactin can act as a suppressor of the HPG axis. So it prevents ovulation, and this can be sometimes considered a natural contraceptive. Um, so now we're going to talk about fertility, infertility, um, contraception. Ooh. Okay, so infertility is basically being unable to conceive, and I think this is defined as couples being unable to conceive after 12 months of normal intercourse. So this can be infertility can be caused by many issues with this system. So gamete production all the way up until blastocyst implantation. And so it could be like a failure of fertilization, such as the sperm and ovum don't meet, failure of implantation. So this can be caused by anatomical issues, or any of these points can be manipulated for contraception, which is deliberate use of artificial measures to prevent fertilization happening. So I think it would be useful to have this in mind and then think about it in terms of female infertility and male infertility. So let's start with female infertility. So this can be due to like failure to ovulate, the fallopian tubes are blocked, or the sperm are unable to travel or survive, or there's failure to implant, or it can be due to age, which has a big impact on females rather than males. So let's talk about ovulation failure. So GnRH deficiency can cause ovulation failure, and this is when the hypothalamus, which releases GnRH to stimulate LH and FSH from the anterior pituitary, for some reason it doesn't work. So in terms of treatment, you can give GnRH agonists in a pulsatile pattern for this. And so from that, FSH and LH deficiency can also prevent ovulation. So this can be treated by giving supplementary FSH, LH, or in terms of contraception, you can actually block the estrogen receptor to prevent estrogen's negative feedback and during the luteal phase to increase the FSH and therefore LH surge. But this can be quite dangerous and it can cause multiple pregnancies. So this is clomiphene, and maybe it might be interesting if you Googled like Clomid twins. So this is like in the late 90s, there were a bunch of twins everywhere because couples that had issues with fertility were taking this drug, Clomid, which caused like the release of multiple eggs. And yeah, there were quite dangerous stories as well, like 8 children from one pregnancy and complications with that. So excessive prolactin, for example, from a prolactinoma, which is a pituitary lactotroph tumor, can inhibit the HPG axis, blocks ovulation. So similarly, apparently in some regions of Africa, women breastfeed for a long time, and this is used as a natural contraceptive. And if we just think about it, it makes sense because if you have if the mother has a high metabolic demand, like breastfeeding, it's not possible to sustain a pregnancy as well. And this phenomenon is called lactational amenorrhea. And stress can also have an effect on ovulation. So this is again thinking about the metabolic demand. If the body is in stress, it probably won't be able to sustain a pregnancy. So psychological stress, starvation, extreme exercise can stimulate the HPA axis and again, interact with the HPG axis. It could also be caused by Cushing syndrome. So it's just really talking about excess cortisol. So moving on to the oviducts being blocked, it could be blocked. It could be due to the anatomy or such as kinks in the fallopian tube or scarring, say from STDs like chlamydia, which causes like unnoticed inflammation and then scarring upon healing. And then it blocks the passage and so that eggs can't be fertilized or even travel really. Endometriosis, so this is when a piece of the endometrial tissue is found outside of the uterus, and this can cause infertility because if say a piece of the endometrium becomes dislodged, detached from the uterine wall and then blocked in the fallopian tube where it grows and proliferates, it can block the passage of the egg. So moving on to sperm transport, sperm survival. So if the sperm are not able to enter or survive and reach the egg, infertility. So this can be due to, say, cervical mucus composition. So it can be that it prevents sperm motility, it prevents the sperm from traveling up the vagina. So excess vagina acidity. So if it's excessively acidic, it can kill the sperm. Sperm semen is typically alkaline to neutralize this effect. But if the vagina is too acidic, it kills the sperm. And in terms of treatment, this can be alleviated by alkaline douches. Moving on to failure of implantation. So if there's low progesterone, low estrogen, the which are responsible for thickening the uterine lining for implantation. So if there's low concentration of these steroid hormones, it could be that there's inadequate growth and preparation of the endometrium. So it's actually unreceptive to the blastocyst, or say damaged endometrium from fibrosis or pelvic infection or like previous unsafe abortions can cause an inhabitable environment for the blastocyst to attach. Also age. So typically age is associated with a decline in fertility. So this can be like increasing age and then eventually menopause altogether is when typically at the age of 50. So I think the range is we say is 45 to 55. And this is when you have like no more follicles left, or like perimenopause is atresia. So when you're decreasing the number of follicles, so it's associated with permanent cessation of fertility, and there's no more ovum. So it's the end of the reproductive life. So moving on to male fertility, we can again use this like gamete production, release, transport, fusion, implant, not really the implantation, and talk about male infertility. So in the case of males, it's low sperm count, low sperm motility, abnormal sperm, defective transport, age. So low sperm can be due to hormone imbalance. So altering the HPG axis, GnRH, FSH, LH, or say if there's increased prolactin for some reason, increased inhibition, reduced spermatogenesis. Then it could be due to the lack of testicular response to gonadotropins. So perhaps by structural abnormalities, damage like physical damage, cancer chemotherapy, radiotherapy, so damaged spermatogonia. So in terms of treatment, it can be cryopreservation of sperm beforehand, storing for future fertilization. So so you can also have a varicocele, which is when there's a varicose vein in the testes, which increases the testicular temperature, and this warm blood can reduce sperm count. Um, so by thermal damage to the sperm DNA, denatured cellular proteins. So you can have dead sperm, like necrozoospermia. Autoimmune conditions can destroy sperm with self-antibodies. Um, yeah. So moving on to low sperm motility. So this would prevent the sperm to be able to swim up the reproductive tract. So immotile sperm cannot move up the reproductive tract in the female, so it's unlikely to meet and eventually fuse with the ovum, causing infertility. So Carter syndrome can cause infertility. Asthenospermia is when the sperm has low motility, or acephalic sperm, and this is like headless sperm, so it can't swim up. Similarly, abnormal sperm. So globozoospermia is when there's no acrosome, sperm have a huge round head and cannot penetrate the egg. Necrozoospermia, so all the sperm are dead. And teratozoospermia means that the sperm have morphological defects such as two heads, two tails, and which can inhibit appropriate sperm transport. Finally, defective sperm transport. So this can be due to occluded vas deferens, which prevents the sperm to travel to and out of the urethra, erectile dysfunction, inability to maintain an erection to ejaculate. Clinically, you can give sildenafil to help with this. And finally, moving on to age, it's not as dramatic in males as it is in females. But apparently there is a reduced testosterone, which is often called a male menopause. And in terms of treatment, testosterone supplements may help with this. Okay, so now talking a little bit about fertility and how fertility can help overcome infertility. So you have IVF, drugs, IUI, and ICSI. So IUI is intrauterine insemination, and this is so so I think it's really important to make sure that we all know the difference between IVF and ICSI. So in IVF, in vitro fertilization, the sperm just are left to penetrate the egg themselves. So in order to have successful IVF, we need to ensure that the male sperm is all right and there's no like issues with motility or anything like that. So IVF may be appropriate for, say, conditions where the fallopian tube or the vas deferens are affected. ICSI, on the other hand, is when you take the sperm and you just pop it into the egg. And this is really for immotile sperm. Yeah. So again, this is talking about different contraception methods. Yeah. But yep, that's it. If anyone does have any questions, please do feel free to ask them. I'll hang around at the end. Do fill in this feedback form. I'll see if I can type it into the chat as well. Um, and my email's there as well if anyone has any questions. But I hope that was helpful. Good luck with all of secondary exams. Oh my gosh. It'll be fine. But other than that, that's it from me. If anyone has any questions, I'll hang around for a bit. But I hope that was useful and I hope it all made sense. Okay, so this is an interesting question. Is dopamine involved in lactation and breastfeeding? So if we just go back to that diagram, oh, let me see if I can find it. So when typically dopamine inhibits prolactin, which is not necessarily the case for all the other axes in the like concerning the hypothalamus and the pituitary gland and then the target organ. When we are talking about lactation though, prolactin, um oh, I'm getting confused now. Hold on. Okay. The suckling stimulus, it is like has a positive effect on oxytocin, but a negative effect on dopamine. And this is important because dopamine would otherwise inhibit prolactin. So with dopamine now inhibited, it means that prolactin is not inhibited, which allows for milk production. I hope that makes sense, but hopefully this diagram explains it better than I just did. No worries.